Good evening, everybody. We're going to have a great web presentation on stroke, and we have a distinguished faculty. So let's get started with Dr. Kaplan. Dr. Kaplan, what is a stroke, and are there different kinds of strokes?
Sure. I think in the simplest of terms, a stroke is a brain attack caused by interruption of the normal flow of blood to and within the brain. This leads to damage to the brain tissue, which can lead to various symptoms. There are two main kinds of stroke, ischemic and hemorrhagic. An ischemic stroke is when there is a blockage of one or more of the blood vessels in the brain, often due to a clot or cholesterol plaque that prevents oxygenated blood from reaching certain parts of the brain. This lack of oxygen causes damage to the brain cells, also called neurons, leading to various neurologic deficits such as weakness, numbness, confusion, speech changes, vision changes. And approximately 80% of all strokes are ischemic strokes. A hemorrhagic stroke is due to the rupture of a blood vessel causing release of blood into areas of the brain where it normally doesn't flow. High blood pressure is a major risk factor for hemorrhagic stroke and strokes in general. So when blood leaves the vessel at high pressure, it can cause damage to the surrounding brain tissue. Within the category of hemorrhagic strokes, there are intercerebral hemorrhages, where blood is within the brain tissue itself, as well as subarachnoid hemorrhages, where blood accumulates between the brain and the closest of the protective layers, the arachnoid layer.
Perfect. Well, thank you very much for that. Dr. Pothanini, why is atrial fibrillation a risk factor for stroke, and who should be most concerned about this?
Yeah, thank you, Dr. Park. Atrial fibrillation is a very, very common risk factor for ischemic stroke specifically. When somebody has atrial fibrillation, there's a lot of stasis of blood that happens in the upper chambers of the heart. And when blood has stasis, it tends to clot. And because these clots form in the upper chambers of the heart, they can always break off, go to the brain, and block blood circulation to the brain, as Dr. Kaplan mentioned. People who would be most concerned about risk of stroke when they have AFib are people who have other comorbidities. And we have different scoring systems we use. The one mentioned here is called the CHA2DS2-VASc score, which is the most commonly used scoring system, where we look at different parameters like age, gender, presence or absence of hypertension, diabetes, a previous history of a stroke. And we take a scoring system into consideration in assessing an individual's risk of stroke when they have atrial fibrillation.
Fantastic. And we're going to talk a little bit more about this and scoring and who might be candidates for interventions. But is AFib, Dr. Pothanini, is AFib an ablation for AFib ablation an option for after stroke related to AFib?
Yeah, that's a great question. AFib ablation is a procedure that we commonly do to help people who have symptoms of atrial fibrillation or who have heart failure from atrial fibrillation to help improve their overall heart status. But as ablation became more mainstream in the treatment of atrial fibrillation, we have now good emerging evidence that AFib ablation can actually modify the disease progression and can even reduce the risk of having an ischemic stroke. There was a very recent large randomized trial called the OCEAN trial, which showed that after a successful the overall risk of a stroke is extremely low, almost equal to that in a general population. So the short answer is yes, there is data showing that modifying the disease burden of atrial fibrillation can lead to a reduction in overall stroke risk. And even after someone has had a stroke in appropriate patients, choosing ablation as a rhythm control strategy has a lot of benefit.
Fantastic. Dr. Paznuri, what are some other cardiovascular causes of stroke?
Yeah, like Dr. Pothanini said, atrial fibrillation is a major cause of stroke where blood clot can form in the heart and go to the brain and cut off the blood supply. But there are other heart conditions that can do that too. If you have the heart function, if it's weak, that can set up a formation of a blood clot. If the heart valves are diseased or damaged, that again can set up blood clots that can go to the brain. If you have a hole in the heart, and I think we'll talk about this a little bit later, it's called patent foramen ovale or atrial septal defect. Blood clots that form in the veins, even in the legs, can go across the hole into the brain and cause a stroke. You can also, outside the heart, you can have cholesterol plaque buildup in the arteries going to the brain and cut off the blood supply directly by decreasing the blood supply by from the narrowing itself, or sometimes the cholesterol plaque or a blood clot can form there and go to the brain and cause a stroke.
And Dr. Kaplan, how do you recognize symptoms of a stroke, and what should one do if they notice such symptoms?
Well, we use the mnemonic BFAST. That's the latest one from the American Heart Association, American Stroke Association. B is for balance, so sudden dizziness, difficulty walking or keeping your balance. E is for eyesight changes, such as sudden vision loss, blurry vision, or double vision. One eye or both eyes, both are considered emergencies. And of course, sudden vision loss or sudden blurriness is considered an emergency as well. F stands for facial droop, is one side of the face drooping. Asymmetry can be seen at rest sometimes, or with smiling, or if they have a grimace. Ask the patient or the person to smile, and if it looks like the one side isn't moving or it's asymmetric, that could represent a stroke. Arm weakness is the next letter, which really is for arm or leg weakness. Can be seen such as inability to hold objects, inability to use a phone suddenly. Any sudden onset of weakness or incoordination becomes a concern for stroke. Can they hold both arms above their head without moving them? And then speech difficulty, slurred speech, confused words, inability to understand what's being said to them. These are all signs of speech impairment that could be signs of a stroke. And finally, T is time. So be fast, call 911. The fastest way to get help is to call 911 for EMS. And depending on what paramedics and EMTs find on exam, they may take you straight to a larger hospital that has certain types of interventions, such as thrombectomy capabilities. Studies have repeatedly shown transport by EMS leads to better outcomes for all stroke patients. So highly recommend calling EMS if there's any concern for stroke.
So kind of time is brain and time is heart muscle, right? In the same
Absolutely.
way. Dr. Kerber, and this kind of goes back to the role of atrial fibrillation in genesis of stroke. But who should be on blood thinners to prevent a stroke?
Yeah, thank you, Dr. Park. That's a good question. This is probably one of the biggest things that we deal with in clinic with referrals and patient questions about, do I need to stay on blood thinners? And it's a pretty clear answer when you think about the mechanisms that cause stroke in atrial fibrillation. It's mainly when the atrium, they're not squeezing, the top chambers are not squeezing all the blood out. So when blood pools, that causes the clots, and then that can lead to a stroke. And so we do have scoring systems that we look at different comorbidities that patients may have to help us guide whether or not they need to be on a stroke or need to be on blood thinners to prevent stroke. And so a lot of it just depends on what comorbidities you have, like if you have heart failure, if you're advancing in age, if you also have hypertension, high blood pressure. If you've had a prior stroke or blood clot, that makes you even higher risk. So then we definitely want to have you on blood thinners. But that's a discussion that you need to have with you and your doctor to weigh the risks and benefits of all the comorbidities of your whole clinical picture.
There's a dark side to blood thinners, though, aren't there?
There is. And that's where everything we do in medicine has a risk and a benefit. And so when you go into atrial fibrillation, your risk of stroke goes up. And so to combat that, we put you on blood thinners, which lowers the risk of stroke, but then that can increase the risk of bleeding. And so then what we do kind of depends on how high that risk of bleeding gets. And if it becomes an actual bleed versus a theoretical risk of a stroke, then we're kind of forced to do something different. And so people that have a high risk of falling, or if they've had previous falls, unsteady on their feet, if they've had prior GI issues and have had to have blood transfusions, that puts them at the highest risk of rebleeds being on a blood thinner.
Dr. Kaplan, would you say in general that a hemorrhagic stroke is more disabling than a ischemic stroke?
Yeah, I think that's a fair thing to say. What we typically see with strokes, especially with ischemic stroke, is you have improvement out to 90 days. And the brain is actually quite good at kind of rewiring itself in cases. But it seems to be with hemorrhagic strokes, we see a little bit less recovery at times. So we certainly watch out for those.
Are there any determinants or risk factors for developing a hemorrhagic stroke?
Prior hemorrhagic strokes, uncontrolled blood pressure, anticoagulant use certainly, antiplatelet and anticoagulant use together, which is certainly needed sometimes. Those can all present risk factors. And then there's various genetic diseases as well that can lead to weakened vessels that may increase the risk for it.
Dr. Passaneri, we alluded to this earlier, but what is a PFO or atrial septal defect? How does it cause strokes and how do you treat it?
Sure. PFO stands for patent foramen ovale. It's a hole in the heart. When a baby is in the womb, everybody has those. And when you're born, a majority of them close. Maybe 25 to 30% of them do not close. Atrial septal defect is just a congenital hole in the heart. With either of these two, there is a chance of blood clots going across the hole and going to the brain and result in a stroke. Normally, what happens is if there is a small blood clot in the leg, it goes from the top right to the top bottom chamber, goes into the lungs and gets lodged there. Now, if you have a hole, especially if there's an increased pressure when you're coughing or playing, sports, even a sesame seed-sized clot can go across this hole, the left side, and then go to the brain and cause a stroke. We usually suspect this if a younger person has stroke and we don't find a cause for it, and then we do what we call a bubble study, where we inject some bubbles into the veins, and under ultrasound we see if the bubbles are going across the hole to the left side, from the right side to the left side. The treatment is very easy for first of all, not everybody who has a hole needs to be closed. Okay, we don't know why some people end up having stroke, why some don't. We do know that if the hole is bigger, that increases the chance of a stroke. If the separation between the two top chambers, that's called the interatrial septum, if it's too floppy, we call it aneurysmal septum, and that again increases the chances of having a stroke. But if a person has a stroke and we do see a hole, then that's an indication for closing it. And there are very minimally invasive, catheter-based techniques where we can actually go through a needle puncture in the groin through the vein actually, and then put a clamshell device across this hole and close it. And over time, the heart tissue, kind of grows over it and seals up the hole. With this procedure, the chances of having a stroke go down by about 50% or so.
Great. So we do have a possible treatment for these people with PFOs.
Yes.
And Scott, what are other catheter-based interventions that can provide stroke prevention in patients with AFib?
Yeah, that's a good question. So back to what we were talking about before, how sometimes people are too high risk to be on blood thinners. We still have to deal with stroke in these people. And so we have catheter-based procedures where we go up through the groin, kind of like what our last speaker was just talking about. And most of the blood clots that form during atrial fibrillation actually come from a pouch that is in the top left chamber of the heart, the left atrium, called the left atrial appendage. And so we can actually go in and find this appendage and put a plug in it that kind of seals itself off, so then all the blood clots that would form behind that plug cannot get out and actually cause a stroke. So that's a great procedure that we can do that can really help us in that rock and a hard place when patients have high risk of stroke and a high risk of bleeding. And overall, this is a pretty safe procedure with with a very minimal complication rate.
Yeah, and we have it's a scoring system, right, to determine who is at higher risk for bleeding events, right? We call it
Correct.
as bled score.
Correct.
And that is the challenge in that we want to protect people from strokes, yet not subject them to the attendant risks of the blood thinner. And technology keeps on progressing, and we have had improvements. But Scott, why don't we go over some of the different ways that we can close the appendage?
Yeah. So on the left side of the screen, that's probably the one that's been around the longest. That's called a Watchman device. And so that's a device that we go in, and it's an endocardial, meaning we go in through the vein in the leg, feed it up into the heart, cross over into the left atrium, and then we put that plug in it. And that plug that you can see has this little white mesh over it, and the body actually will seal itself off over that. And so that does a great job of protecting the blood clots from behind that from getting out and causing a stroke. So that's one of the options. And then on the bottom slide, bottom part of the slide, that's called a lariat. And so that's kind of a combination of endocardial and epicardial, meaning we go inside the heart like we do for the first one that I described. But the way we isolate the appendage is actually from the outside of the heart. So we put a needle into the epicardium, and in between that and the pericardium, the heart and the pericardium, so outside of the heart. And then we put this snare over it, and then we squeeze it from the outside to occlude it. So all of these are different ways of occluding it. And then there's another device that was more recently created right above that. That's also an endocardial plug that has a little kind of a shelf that will do a better job at blocking more proximal related side lobes of an atrium, or not every atrium and atrial appendage is shaped the same. So these are just different ways of going about doing the same process, occluding the appendage. And then surgically on the right side, if you're undergoing another type of procedure, they can do that surgically and put a clip on the outside. And so one of the benefits of that and the lariats is not only do we occlude it from causing a blood clot, but we also electrically isolate it. So like Dr. Pofanini was talking about, different signals that can cause AFib could sometimes come from the appendage. And so this can also electrically isolate it, which provides an advantage.
I find that the appendage is a lot like a fingerprint. Everyone is a bit unique. And I think depending on the anatomy, one device might be more suitable than the other.
Agreed.
Dr. Puznuri, what is the role of implantable cardiac monitors in the management of stroke?
Yeah, that's a great question, Peter. Atrial fibrillation, as we alluded to, it's a major cause of ischemic stroke, especially in older patient population. Now, a lot of times this can be asymptomatic, without symptoms. So in a patient who presented with a stroke and we don't have any other clear cause, especially if he's older gentleman, we call that cryptogenic stroke. Getting just an EKG might not make a diagnosis. If you put a patch on the skin, the external monitors, you can only monitor the heart rhythm for 2 to 4 weeks or so. We cannot monitor it long term. So the implantable cardiac monitors, they give us a way of doing a continuous and long-term and remote monitoring for as long as 3 to 4 years. It looks like if you look at the screen there, the size of it is almost like a AAA battery. It takes about a few minutes to put it under the skin, outpatient procedure, and we get good reading of the EKG. We can, interrogate the device every month and see how much, or if you have any AFib or how much AFib, atrial fibrillation you're having. It not only provides us a good tool for diagnosis of atrial fibrillation. It also helps us manage atrial fibrillation better. When we need to escalate medications, when we need to get the patient over for ablation, it's a great tool.
Dr. Kaplan, out of all the strokes that you see, what percentage do you think are cryptogenic strokes that would fall in that category?
Around 20 to 30% total, I think, are cryptogenic at this point. Oftentimes what we have is we'll find, for instance, when we use the loop recorder, we'll find atrial fibrillation later on. But in the hospital setting, I would say it's approximately 20 to 30% are cryptogenic.
Now, lacunar strokes, do you find are generally with hypertension then? And
typically, the main risk factors we look for that are high blood pressure, cholesterol, diabetes, and smoking. Oftentimes, we see high blood pressure. That is the number one stroke risk factor, so that often is associated with it.
And Dr. Kaplan, in the aftermath of a stroke, what should one look for?
Well, immediately after a stroke, the first step is stabilization in the hospital. And then based on various laboratory tests, imaging, physical tests, and medical history of the patient, we work to try to determine what the cause of the stroke is. Unfortunately, as we just talked about, 20 to 30% are cryptogenic, or we don't know the exact cause. And so following that, we really look for what ways can we use to reduce risk factors. So we look at patients' individual medical history, what we believe may be their personal risk for stroke, and then try to address that with various medications and possibly techniques such as the atrial appendage occlusion. Also following a stroke, we see patients will have cognitive, physical, emotional symptoms, and even fatigue and trouble sleeping. And so we work very closely with physical, occupational, and speech therapy to assess what the patient's needs are and get them set up at the time of discharge. Possibilities include going to, say, a skilled nursing facility, an inpatient rehabilitation center, or even home-based therapy if they do especially well, really dependent on each individual person and how they're recovering from their stroke.
Yeah, I find that it's truly a multidisciplinary approach, a multi-pronged approach to take care of these patients.
Absolutely. And we really enjoy working with the cardiology group because you guys do so much with the atrial fibrillation and the occlusion devices. So we have a lot in common with our patients.
Now, does stroke run in families? And if you find that you have a lot of family members with stroke, what should you be worried about?
Yeah, absolutely. Stroke does run in families, especially if you have a family history of stroke, like a first-degree relative with a stroke before the age of 65. That increases your personal risk for stroke pretty significantly. So we always recommend start with your family doctor and review of potential stroke risk factors. Kind of the top 5 stroke risk factors would be like high blood pressure, diabetes, cholesterol, irregular heart rhythms, and a prior TA or stroke. And then after that, we really look at other things such as smoking, obesity, physical inactivity, sleep apnea, various vascular diseases, heart disease, even gum disease presents a risk for stroke. And then you start getting off into some smaller things such as blood clotting disorders or sickle cell disease. But certainly if you have a family history prevalent for stroke, you should be evaluated by your primary care and discuss your concerns with them so we can start addressing risk factors early on.
Thank you so much. So I'm just going to put this out to the whole group. What do you think the future of stroke management, stroke prevention holds, especially within the context of cardiovascular disease, including atrial fibrillation?
I think one interesting thing is, indications are constantly changing for use of these implantable devices that we talked about. And so the technology has gotten so good with loop recorders and our plugs, left atrial appendage occlusion devices, that there's some studies that are being done to see if maybe these are better than being on a blood thinner anyway. And so, there's a lot of downsides to anticoagulation in certain people. And so as indications and new inventions and technology gets better, maybe we'll get to the point where we don't have to have a lot of people on long-term anticoagulation.
It is pretty amazing, right? That within that realm, 20 years ago, all we had was warfarin, and now we have safer drugs, and we have strategies that don't require drugs. And I think there's also still excitement with new drugs that potentially might be even safer, right? Like the factor 11 inhibitors that are going to be coming on the market soon.
You know, studies are showing, as you noted, that potentially we'll have the choice of can they go on blood thinners or can they get a left atrial appendage occlusion. Maybe they'll become like equal or potentially outperform it in the future. Safer drug profiles will be coming out. You know, everything we can do to prevent another stroke and keep the patient as safe as possible in the meantime, I think would be great. Like you said, warfarin, we had warfarin and now we've got so many better choices, and it just keeps going in that direction. It's really neat to see.
Well, technology advances, and it's an amazing time to be in this field. I want to thank all of my faculty, and I hope everybody has a great night.
Thanks, Peter.
Bye-bye.
Thank you, Peter.